So we can get started. Okay. Can everybody hear me? All right, I'm getting a thumbs up. Okay, perfect.
And you can hear me.
Yes, we can hear Dr. Chrisman. Okay. Okay, so Smita posted a message in the chat. She'll be in the background, so she'll be available for any kind of technical troubleshooting. And the way you can reach her is by sending her a private message in the chat. I'm Allison Cotton. For those of you who don't know me, I'm one of the admin team, one of the co-founders of Physician Support Line. And we have today with us to give us our talk, Dr. Allan Chrisman. He'll be giving us an overview of the stress for physicians in the time of COVID-19 with a focus on anxiety, insomnia, and grief, and the role of the physician support line. The way we'll handle questions is we can do the usual raise hand. That's my dog. We can do the usual raise hand option in the chat, or you can send me a direct message if you feel more comfortable doing that, and I can ask your question. Does anybody have any questions about that? No, we're good to go. Okay. All right. So without further ado, I will let Dr. Chrisman introduce himself and get started. Dr. Chrisman, do you need to use the screen share?
I do. So let me just start that here.
Okay.
Uh,
I'm going to keep admitting people. Perfect.
Okay. So hello, everybody. I'm Allan Chrisman. I am co-chair of the North Carolina Psychiatric Association Disaster Committee, and I'm also associate professor emeritus from the Duke University Medical School, where I had a multitude of roles over the years, including the pleasure of being the child training director for a number of years. And towards the end of my career, also started working concurrently at the Veterans Administration Emergency Room and their acute access evaluation clinic. I'm also a Red Cross disaster mental health volunteer, starting back with Katrina, where I was deployed down the coast and worked in shelters. Since then, I've worked in other national deployments, and mostly recently in North Carolina, where we have lots of natural disasters, including hurricanes, tornadoes, floods, and now a pandemic. So today, I wanted to sort of give a bit of an overview of the nature of the crisis that we're all in. I have been really very busy with my role in North Carolina in the disaster committee. We started almost 8 weeks ago having our morning report call, where we collect information from the membership throughout the state and the academic institutions on the impact that the disaster's been having, and trying to come forth with ways to support people. And we've done a number of things in the state, which will be touched on in some of the slides coming up. Concurrent with that, there's a weekly call with the American Psychiatric Association Committee on psychiatric dimensions of disaster and COVID now. And we nationally have been collecting information and from membership and in agencies and putting together sets of guidelines. And so both at the North Carolina Psychiatric Association, we have a website we populated with a lot of information about what we've been up to and what will be helpful for practices and individuals. And likewise, the American Psychiatric Association has done the same. And also for the Child and Adolescent Psychiatry group, I'm on that. I'm a member of that committee for disaster and trauma issues. We have also been providing a lot of information on that as well. So without further ado, let's go. So I'm going to give the initial introduction here from what is typically the disaster impact pyramid that we usually are dealing with. As you see, that structure is used for lots of different images, including ACEs. But we're not in that now. We're in the bottom one. The pandemic has basically been like a giant foot that has flattened everything out. So we are in time of almost total disruption of our society, community, healthcare system, you name it. And it's unprecedented. There are many different unique aspects to a pandemic, which we have also to address, and that will be something that will come up, I'm sure, in other slides and questions and answers. I want to show what we normally see as we call the resilient zone, which is how people would typically be able to manage the impact of a stressful event or a trauma in their lives to maintain a certain range of stability. And in this current circumstances, we are much more likely to see dysregulation, so that you can get stuck in the low hypoarousal zone, where depression, isolation, exhaustion, fatigue, and numbness, or you can get stuck in the kind of upper zone of hyperarousal. So there you have anxiety, panic, rage, pain. So these are the conditions, particularly that you're going to be dealing with in the support calls that you get. So what about caring for healthcare workers in this crisis? Well, we know from results of healthcare professionals that the study out of Stanford recently published in JAMA, that there are 5 things that healthcare professionals want from the organizations where they'll be working in the crisis. And they want to be heard, they want to be protected, they want to be prepared, they want support, and they want to be cared for. So let me walk through those 5 in a little more detail here. Particularly around hearing me, the principal desire is that they want to be listened to as healthcare professionals that have expert perspectives and frontline experience, and they want to have an understanding with the leadership that will address the concerns. And the concerns that they have is at this stage is, I think, still continuing. There's a lot of uncertainty about how leaders recognize what are the most pressing concerns of frontline healthcare professionals, and whether the local physician expertise regarding infection control, critical care, emergency medicine, and mental health for us are being appropriately harnessed to develop organization-specific responses. And so the key component of response that they're looking for in this regard is that they want to see an array of input and feedback channels, listening groups, emails, suggestion boxes, town hall meetings. They want the leaders visiting hospital units, and they want to make certain that the voice of healthcare professionals is part of the decision-making process. So the next piece is under Protect Me. Again, this desire is to reduce the risk of healthcare professionals acquiring the infection or being a portal of transmission to their family members. We know that from previous experience with SARS as a pandemic, that healthcare professionals who have family members are at heightened level of stress compared to those that don't. So this is a particular area that's important to pay attention to. And the concerns here, again, about the access to appropriate PPE equipment, the risk of, again, taking home infection to family members, not having rapid access to testing through occupational health if needed. And then, of course, the response they're looking for is, again, adequate PPE and a rapid support access to occupational health. And they also want information and resources to help them avoid taking the infection home. There's, again, been a tremendous amount of ongoing uncertainty about the nature of transmission of infection. Every day, you see almost new studies and articles coming out, whether it's you're going to be on surfaces or not, how close you have to be to people. So they want accurate and timely information. They want transparency in their communications with the leadership and with the expert resources. Prepare me includes that they want the training and support that allows the provision of high quality care to patients. This is a time when it's sort of all hands on deck, kind of all hazard crisis disaster. And so people are at risk for being pressed into service beyond their typical scope of specialization. I had a colleague, a child psychiatrist I know in New York, who was telling me that early on in her hospital, she was given a directive to report to a COVID floor and to be part of the medical team there. She had not, since almost 20 years, been involved in any direct medical care, especially inpatient intense care. And this was highly stressful to her. Fortunately, after one day of doing this, she was able to reach out to her department chair, and this was corrected because she had had no training, and that was not the best use of her expertise. But that's an example of the kind of concerns that can actually be harmful to healthcare professionals and certainly physicians as we're talking about it. So again, getting rapid training to support basic critical knowledge base and appropriate backup and access to experts, clear and unambiguous communication, which acknowledges everyone's experiencing novel challenges and decisions and the need to rely on each other. And individuals should be able to ask for help when they need it, and no one needs to make difficult decisions alone. Isolation is a huge issue, whether intended or unintended, in the sense that we're all in this together. Support me. So this principal desire is to provide support that acknowledges human limitations in a time of extreme work hours, uncertainty, and intense exposure to critically ill patients. So the concerns here that the type of support for personal and family needs as work hours and demands increase and schools and daycare closures occur. I'm still very directly involved with Duke, and I have actually neighbors who also work in critical care. And I know one young family nearby, the mom is a OBGYN oncologist, surgical oncologist, and the dad is a intensive care specialist. And so for the two of them, when the closure of daycare occurred, that was a critical time of anxiety as to how to get appropriate care. The medical school actually very quickly responded to that reality, and a lot of the medical students volunteered to provide daycare. And the next day after this, I remember seeing a young medical student walking in the neighborhood with the daughter of this couple, and that's what her contribution was. I know on a statewide basis, we very actively worked with the governor and the various agencies to assure that essential workers had daycare access, and we have a support line that we've created in this state in conjunction with the state through a disaster response network that I'm part of, and the child care workers were included as being eligible to call that crisis line for support given the stress that they're under. So this is a very important area. So again, if you look at the Maslow hierarchy of needs, you're seeing that key components here for support do include access to healthy meals and hydration while working, lodging for individuals that are in rapid cycle shifts who don't live in close proximity, transport assistance, all kinds of additional ways in which people are actually provided for their physical and emotional well-being. And so all of this is been paid attention to, and we're going to be talking about it a little further. So care for me here is this holistic desire to, again, include everybody in the individual team and their families if there is going to be quarantine. There's uncertainty how organizations will support or take care of these sort of collective needs if the professional develops an infection. Of course, people working in this environment are going to be highly likely to be exposed to and become infected. And sadly, that has happened with a degree of frequency that we all feel very sorry about. So again, here we're talking about how appropriate well-being is supported through adequate childcare and food, check-ins, emotional support, and paid time off if quarantine is necessary. So all of that translates back to, again, this question of what are the main sources of stress in the workforce? Well, we've done quite a panoply of areas, but they were able actually to boil down to 4 different kinds of categories: that there's a threat to the workers' personal and family health and life. There's the threat of loss of colleagues or threat of professional mastery and identity. As I was explaining earlier, if you're being asked to be going back and to do direct medical care and you haven't been doing that recently, that's quite a challenge. Then we have the inner conflict between one's values and aspirations and what they're able to accomplish in the work. And then there's fatigue, simply being worn out by the relentless work and need without adequate time for rest and recovery. So this kind of stress results in stress injury, and there are recognized 4 different areas. So there's life threat, which is a traumatic injury due to the exposure to intense injury, horrific or gruesome experiences of death. There's loss, a grief injury due to the loss of people, things, or parts of oneself. Inner conflict is a moral injury due to the behaviors or witnessing of behaviors that violate moral values. And then there's the wear and tear or fatigue injury due to the accumulated stress from all sources without sufficient time to rest and recovery. So if left untreated, the acute stress reaction can evolve into a persistent social or occupational impairment, depression, anxiety, substance abuse, PTSD, and suicidal ideation. And proactive institutional supports initiated before crisis, stress first aid delivered during the crisis, and recovery aid provided after the crisis do increase the odds that individuals recover and thrive. So we know from the studies that were done after SARS for healthcare workers in these situations that these particular types of stress injuries occurred, and that in situations where the appropriate response had not happened, there were pretty significant lingering impairments in work performance and other ways in the personal life. The interesting outcome in that particular set of studies did not show that people developed disorders per se, such as PTSD, but they had subthreshold symptoms that led to this impairment. And I would throw in an epidemiological perspective here that the largest population-based study looking at stress and the development of disorders throughout a lifetime, starting with preschool children, the Smoky Mountain study done in North Carolina, showed that, ironically, the majority of people that showed significant impairment and needed intervention didn't meet criteria for full diagnosis, so that there's a subgroup within the population that suffers and struggles and really has all the indicators for needing intervention, support, and care, and aren't getting it because they don't meet the full diagnostic criteria. So that's an issue which I'm sure you'll be wondering about as you are involved with the care of people. So again, we're looking increasingly at a public health crisis and a public health perspective and trying to understand the best way to provide a response in the situation. So this is the overall model that was developed. Again, if you want to see the full study, the full report, the American Medical Association has actually on their website this particular document, which is actually quite good and worth looking at in more detail. So I just wanted to give you a sense here in terms of what we've talked about, how there are ways in which you can see a flow sheet this plays out. So there's the crisis, there's the stresses, and then there are, looking at that, pre-existing institutional supports. A chief wellness officer has surfaced as a critical element in an institutional response these days, and some institutions have done that well, such as University of California, Davis. Peter Yellowis, who is also chair of the APA Telehealth Committee, is the chief wellness officer there, and he's done an excellent job. In fact, it was such a good job for the medical center that the university at large asked him to actually also be involved in the kind of messaging and support that he was offering. He has a series of good news letters that come out weekly and that give excellent sort of shout out supports and recognition. You can also try spelling it. Again, if we walk through this very quickly here, you're going to see beyond the stresses and the institutional supports that the stress injury is occurring, and then shows if there's no intervention, what the chronic reaction would be, and if there is an intervention, listing the stress first aid that we've talked about. You can get coping and recovery, and then ongoing recovery aid is going to be really important as well. And I would point out that the crisis work that you're doing with the support calls can fit in multiple ways in these various types of responses. So looking more at the detail of psychosocial and mental health needs that is been identified in these models, we can see on the left a list of categories which quickly include psychological safety, peer support, partner and family support, supportive one-to-one conversations, unit briefs, confidential support and referral hotlines, mental health crisis teams, mental health liaisons, telepsychiatry, and self-care. I would let you know in terms of how this is playing out. An example on a call I was on this week with a health system in North Carolina that had put together an opportunity for a peer support group. And the question, the reason that we were partly having the call was to ask for help because there were 2,000 people in this institution. And when they set this up at different times, they had hardly anybody volunteer come to ask to talk during these support groups that were offered. And so the question that we looked at was, what was going on? Why would that be? And I think the answer that we came up with, because some other institutions that were on the call had addressed this in a different way that was more effective, is that you need, everything is context. So you need ideally to have these peer support groups occur in the context of a work group. And so if you have just a general opportunity for people to drop in, but they have no direct work relationships with each other, there's less of a tendency to do that. We know that as far as stress reactions and coping, avoidance is probably one of the most common ones. It's a prime feature of PTSD as well for the more severe form of the disorder. And getting people to come in for treatment is not easy. And so we even discussed the idea of not even labeling it one thing or another. So the issue of stigma, and we're talking about medical colleagues now who don't feel that they need help or don't know how to ask for help. So again, meeting them at the place that they are in their work experience is really crucial for a lot of these efforts. So again, supporting the workforce after the crisis, it's important to continue to provide confidential and readily accessible emotional, psychological, and mental health support for 6 to 12 months after the crisis has passed. And we include here telephone support lines, virtual visits, and in-person visits. And it will include collegial support groups, as I've talked about it, which provide an opportunity to find meaning in this tragedy and allow for a sense, making sense of an intense, uncontrolled period of time. And I think that this issue of reintegration support, we would call it, from my work at the VA and also talking to other colleagues who've done a lot of this work, coming out of a very intense, almost shared identity that you have with people that you wouldn't otherwise work with. And it can be life-threatening, and you see a lot of gruesome things, and then you suddenly are back home, and you're in a situation where you're back at work, and all those people that you work with aren't there to share the experience or process it, is really tough. And for those that potentially were in quarantine, away from their families, they come back home, and suddenly in that family situation, they find there's been a lot of change because they weren't there. Things had to be done differently. and they're not quite sure how they're fitting in, or they may come out of that intense experience at work only to be told by a spouse with children, you know, you take over, I've had it with how I've had to cope with this. And so suddenly they have that added stress. So the issue of reintegration is going to be a huge one at this point moving forward. On the APA national call this week, this was a hot topic, and we're trying to figure out how to put forth some guidance on that as well, but you should be aware of that in your work. All right, so I've thrown a lot at you at the outset. And the question, of course, is, so what does help after a disaster in terms of a survivor's perception? Because normally people might think, oh, a helpline, a support line is just minimal. It's not that effective. It's not that important. Well, it turns out to the contrary, when it got studied after a really horrendous disaster that affected a community, that all of the ways in which people were being offered therapy and talking to individuals and having peer groups wasn't that well received. It turned out that the helpline, the support call-in line that they had put up, was deemed to be the most effective and helpful by the members of the community. And that was followed by support group, a reunion of sorts. Individual therapy was only at 44%, medication 28%, and group therapy, surprisingly, was at 14% at the bottom. So why, might you ask, would a helpline be considered so effective? Well, as it turns out, and I was alluding to this a little bit earlier around avoidance, people in the community found that they didn't want, in the usual sense, to go and talk to their friends and neighbors and other people in person because it triggered too much. It was too hard for them to discuss what they had been through. On the other hand, they worried about being judged, about being criticized or appearing weak, that sort of thing. On the other hand, when they called on the helpline, it was anonymous. They didn't have to say who they were. They felt they were free of judgment. They could unload how they felt in full force without getting negative feedback. And that was the first step for them that really gave them a sense of some relief. Not everybody responds in the same way to help. People have different coping mechanisms. And this helpline allowed people to call when they felt they were ready and that they could make use of it. And so the subsequent follow-on that started to happen included support groups in their reunions. Then for those that were, so to speak, resilient and chose not to, going on for actual therapy was on the sort of the bottom part of this. So let's talk a little bit about the crisis support calls that you're doing. Typically, these are going to be very limited. I know in the greater world, they usually are 2 to 3 contacts. I'm not exactly sure how you have been instructed as far as the number of contacts you are going to be having, but it's going to be relatively brief. The focus is going to be on problems of daily living due to the disaster. That's a broad reach, so it's not meant to constrict what you're likely to have as a focus, but it is to say that this is the most common way people choose to use that type of opportunity. The orientation is here and now, supports active and engaged. You identify immediate and concrete tasks for completion in the call if you can. The goal is to engage, the word I'm using here is clients, but you can say colleagues in achieving a new stability, and it's much more directed than traditional mental health work. So what about the skills? So attending skills aren't so simple as you might think. You really need to have an environment where you have minimal environmental distractions. You're going to be using reflection and reflecting process of identifying, making clear, and expressing back feelings and thoughts. And the process involves grasping what the other feels and means, and then stating this meaning so the person feels understood and accepted. So the issue here, in terms of the format, is that you're in fact going to be stating the feelings and facts, and you want to avoid using the question format. So the question format might be, do you feel sad? Well, if you say that, you will, it comes across typically, we found, that you're unsure when you ask that question. You're maybe expressing some sense of unbelieving, and you can also be perceived as patronizing. And questions will force a response from the client and may cause defensiveness. So we want the caller to introduce their feelings only when they're ready to deal with them, and it may be necessary to relect some of their feelings back many times before they get further down the discussion. So it's more of a gradual release of pressure. Some people can let it out all at once, while others need a series of little releases. There are multiple reflections, and that may be a good way of looking at something from different angles until the whole picture is seen. So again, in terms of reflective listening being active, it may seem to you, if you haven't done much of this, that it's a passive process. But to be successful, it relies on intense concentration. We hear more than just the words of the caller. We also hear the feelings, the values, and the attitudes of an individual. And to do this requires empathy and acceptance of the importance of the caller's concern. And empathy literally means to feel in, to stand in another's shoes, to get inside his or her feelings. It's a learned skill, and I know you all have worked very hard, as did I, and still always in trying to improve my experience of it. But again, in the process of you doing this, through attention and practice, you're still going to be able to develop it in using that format of a phone. We look at, by contrast, pity, sympathy, projection, and transference that may masquerade as empathy. So pity is feeling sorry for another and tends to patronize your colleague. Sympathy is feeling for another, becoming emotionally involved, and tends to cause one to be less objective and neutral. Projection, of course, attributes our feelings to another. I would feel this way in this situation, you must also. And then transference is when we react to a client because he or she reminds us of someone else. And all of these situations interfere with, and they distract from, our ability to empathize with another person. So this may seem simplistic to you, and I know that you've all had intensive training, but if you're not used to doing this particular type of work, it's worth hearing about. And so the question people often ask is, why is reflection effective? And the answer is going to be that it's respectful, that helps the speaker feel deeply understood. It serves a supportive function by communicating to the speaker that you are in tune with them. Concentrating how the other person feels eliminates the need for personal judgment. It shows that you are paying attention. It provides the opportunity for emotional catharsis. And since the speaker is free from having to defend his or her feelings, the speaker can face their problems more directly. So reflecting skill is non-judgmental and accepting. You don't pretend you understand if you don't. You don't ever tell the caller that you know exactly how he or she feels. And you vary your responses and monitor your tone of voice. So a great deal of empathy and warmth can be conveyed through your tone of voice. And if the caller begins to ask personal questions or for your opinion, it's best to reflect the feeling behind the question back to the caller. So that's the introduction to the work that you're doing and some reflection on the skills that you'll be using. And so now we're going to talk about 3 areas that I understand from the feedback that has been given on the experience with the calls to date, areas that people would like to hear more about in terms of what to do. So anxiety is at the top of the list. And we're going to talk about psychological first aid. Psychological first aid is something that has been previously talked about on these training calls. You had a very good general historical and overview perspective on that in disasters. We have, in this COVID situation, very actively adjusted psychological first aid as well to healthcare situations. It's been adapted as an evidence-informed type of intervention across the world. So if you go to the World Health Organization website, you will see field manuals and ways in which culturally it's been adapted for different areas, different languages. So this is a common type of intervention that we are all relying on the one hand, in principle, and these are the core actions that, in fact, they all have embedded in the particular version that you can look at. So the contact and engagement, safety and comfort, stabilization, information gathering, practical assistance, connection with social supports, information on distress reactions and coping, linkage with collaborative resources. Again, the purpose of this is to help de-escalate people who are in intense states of feeling overwhelmed. Often they can't think straight, they can't manage their feelings, are dysregulated, and they have to learn to figure out and attend to their immediate needs and those around them. And the way we know resilience is reinforced is going to be through these attempts to help people settle down, gain a focus, understand in their communication with the helpers exactly where they are in their needs and what is going to help them be safe. We rely a lot on resilience with the individual. We don't assume that we have the answers. We're more likely to try and reinforce past experiences with successful coping that they've had. But these are, again, core principles that have been found to be most effective. So this is a little bit of the roadmap to show, in terms of those principles, the way in which, if you're engaging with people directly, and you can also think about it in terms of your support call work, how you connect, help people be safe, be kind and compassionate, meet basic needs, listen, provide realistic reassurance, promote good coping, help people connect, and you provide accurate and timely information, make a referral, and of course the last one is take care of yourself. So this is from SAMHSA. They have an app and a lot of materials on their website that you can get to get more information and functionality about how this works. I'm going to show you part of a handout which I will send to make available. It's a one-pager. It is, I think, at this point, perhaps one of the better ones that I've seen that's been adapted to a healthcare environment. I think the emphasis here is that PFA does play an important role in helping people cope with stressful situations and how you can give emotional support people of any age, ethnic and cultural heritage, and social and economic background in the immediate aftermath of a disaster or in the midst of a public health emergency. And so again, what you will see here on the handout that you ideally will take advantage of will give you some scripts, some particular detail of exactly in these areas, how to proceed with these engagements and how to provide these types of principled supportive intervention. This is the mobile that's free and available. You can download to your app. Many of you probably have it already. It is a good pocket reminder. It has not only sort of ways to remind yourself of this detail, but it also gives you assessment tools for other people to fill out and for you to fill out on yourself, again, around your own self-care. So that's something I always carry and would urge you to have handy as well. So let's talk again about a different approach to anxiety. The mindfulness of anxiety reduction is something that you have previously been presented with in one of the trainings, and I'm just going to quickly touch on that. So there are going to be two dimensions here about immediate phone intervention. And the first one that I'm listing as how to turn anxiety into a focus in 3 easy steps is meant to be, if you have an individual who is talking so fast and seems so scattered that they can't really get a focus with you, you can help be much more directive to get them to deep breathe, take 3 deep breaths, say wheel, reframe your feelings, engaging them to talk, self-talk. Tell yourself you're excited, not nervous. The emphasis I would give you additionally here is that in all of our efforts with COVID, stress and Josh Morgenstein, who's done a training online, free on APA website, is an expert in this. Messaging and words are interventions, and in how you say things makes a huge difference in the way people are queued up or triggered to react. So his example would be to not use the word anxiety, but to use the word stress to try and normalize and to bring the person back into a different sort of state of mind about things. Certain triggers, words that we use very often make people feel more anxious. And so again, the reframing of feelings is really important here. And then there's the physical trigger. So you ask the person to pay more attention what movements or gestures that they tend to do when they're excited. And you can suggest counter things. So clapping your hands, wiggling your limbs can be ways in which people can gain a different sort of focus to get them out of a free state, as it were. And that's something, again, if you're trying to work with somebody on the line, you tell them to, try clapping your hands, holding a piece of ice if that's available, something that would pull them back into their body in a way that maybe they can then use that physical trigger to get into a different mindset, and also to talk to you in a way that you can help them. So the soft belly breathing practice was what was also presented, and you were taught in another training. And this is just a very quick script rundown of how to do that. And I think the breath is what you're focusing on. The idea of soft belly is that is allowing your belly to receive the breath. And then on the out breath, so you say soft on the way in, belly on the way out. And the issue here is that the inhalation soft, when the belly gets soft, there's more oxygen that goes to the bottom of the lungs. And if the belly is soft, it helps to activate the vagus nerve, which promotes relaxation, and it's an antidote to the flight or fight stress response. So again, there are going to be a lot of thoughts, feelings, and sensations that arise during this exercise. And the idea here is to just let it be there, to let it pass, not to focus on it. So again, this is not the training that you're going to get per se, but there are different ways. There are many online YouTube training examples, and I think that's something, if you're not familiar with it, that's worth following up on. So still in the state of anxiety treatment, we're going to turn our attention here to distraction as another technique, and it's the act of deliberately turning your attention away from the crisis. So in dialectical behavioral therapy, there are many acronyms, and with this, we use them as a memory aid to help us remember what all these skills are. And what we like to say with distraction and distress tolerance is that wise minds accepts, and accepts is our acronym of different ways a patient can use distraction. So the first is using activities. That's pretty straightforward. The idea is that you can go and do different activities that take your mind off whatever the crisis is. The second is contributing. And the idea here is that it can be an activity in and of itself, but you go outside of yourself and you ask someone else how they're doing in some way, or doing an activity that contributes to the well-being of someone else to get your mind off your own distress. Third, of comparison, comparing your life how it might have been before and how it might not be as bad as that point, or comparing yourself on an outside to some other situation or other person that might be worse off than your situation. So comparisons can be a wonderful way to start to get perspective on what you're going through now. The fourth is using opposite emotions. That's a common skill in DBT in general, dialectical behavioral treatment. The idea here is that when you get distressed, there are one or two negative emotions that tend to dominate the scene for you. So figure out an emotion that's opposite from the negative one that you're feeling and try to bring it in. If you're angry, watch a comedy. If you're scared, watch someone else that's daring. If you're sad, listen to some upbeat music. Pick an opposite emotion that you can evoke. The fifth is pushing away, and that's really the idea that you're deciding that this is something that can't be dealt with right now, and putting it out of your mind and imagining yourself putting it on a shelf and come back to it later. The sixth is thoughts. It's another way we can use distractions. So the idea is when you're in a crisis that you can't solve, often our minds are stuck on thinking about that crisis over and over. But if you can fill your brain with other thoughts, there's no room for that crisis to be in there at that time. Singing songs to lyrics that you don't quite remember, or counting backwards by some high number by a factor of 7 that makes you must think about it, are often quick ways you can use to fill your mind with other kinds of thoughts. And then the seventh is sensations. And the best strategy to get unstuck when you're feeling very distressed, when you're mobilizing your body and you bring your mind and emotions with it. So you can put your face in cold water, hold on to ice, you can run up and down the stairs or take cold showers. And often people with chronic pain have limitations in the kinds of things they can do. So using sensations to sort of shock the system into distraction can be helpful. So we're looking at self-soothing with the 5 senses. And generally when we self-soothe, we can think of ways to do that with our 5 senses. And you can brainstorm with somebody on a call if that would seem helpful. And again, I don't, because of the time, want to run through all this detail, but this presentation will be made available, and you can look at how you think about this type of approach. It's great to use for yourself as well. So again, vision, sound, smell, touch, and taste, the 5 senses. And then finally, we have, in terms of these techniques, one called Improve the Moment. So here we're looking at skills to accept pain and reduce suffering, but they're applicable psychological pain, anxiety. And so again, here we have imagery, meaning, prayer, relaxation, one thing in the moment, vacation, pleasant activities, and encouragement. These are, again, additional types of ways in terms of, again, an acronym, Improve the Moment, that you can use at times during the call if it seems like that would be a way to engage the person who's struggling with stress. Finally, I'm going to give you, again, I'm not going to read through this, but I found that this was actually very helpful, and I've shared it before, and people seem to feel positively about it. So there are a lot of cognitive distortions that people have under stress. And so here's a list of 10 of them that typically are dysfunctional or negative. And on the right are sort of anecdotes or ways to, they say, untwist your thinking to help address those types of thinking. And so you may find in the call that these cognitive distortions are coming up in the conversation. And if you have these kinds of additional supportive suggestions for scripts, that would be a good coping technique for these people to hear about. Okay, on to insomnia. So I would say very briefly to start out with, insomnia is probably the most common complaint in all disasters, certainly in sheltering work where everything is dysregulated in the environment. You will see in the evening almost all the adults line up before the disaster health services area asking the nurse for Benadryl to help them sleep at night. And we know from the studies looking at COVID-19 in China that more than 1/3 of the medical staff suffered insomnia symptoms during the outbreak, and the correlated factors that seem to make insomnia more frequent and worse was educational level. So people who, in this case, if we're just dealing with physicians, we might, I guess, look at the question of specialty level. If you're out of your area of expertise in these situations, and being in an isolated environment, such psychological worries, of course, about all the aspects of COVID and getting it or transmitting it. So the healthcare workers who experience sleeplessness were also more likely to feel depressed, anxious, and have stress-based trauma. And the most important factor was having strong uncertainty regarding effective disease control among the medical staff. So that factor accounted for a lot of the insomnia that people were struggling with. Again, something to pay attention to. So I'm going to just briefly walk through an overview of the treatment of insomnia in adults that Up to Date has published. For those that you're familiar with Up to Date, it tends to provide the most evidence-based view on available treatments for different disorders. I recognize that there are many alternative means to offer, and sleep hygiene, I'm not going to walk through all of that, of course, is critically important because short-term insomnia, which is the most common form, is thought to be from psychological or physiological stress. And so patients with acute insomnia usually identify immediate precipitant to the insomnia, all the things that we've talked about earlier. So the clinical approach to this is to discuss the role the stressor is playing in disturbing your sleep. And this can provide some control, at least acceptance of the sleeplessness. But when it's more severe, associated with substantial distress, they do recommend short-term use of medication. I know that you're not going to be recommending in this call. I just thought I'd give you an awareness of that was the background sort of suggestion from an evidence-based, reliable source. So the physicians you're talking to might automatically be aware of that, and that might be where they want to focus their attention. However, there are other mechanisms that you will be focusing on instead. And so quickly we get into what's called chronic insomnia, and that's most likely, given the extent of how long this has been going on, and is likely to continue to be the way in which it would be more helpful for the person to get help. So cognitive behavioral therapy is the preferred treatment, and it's endorsed as a first-line therapy by multiple medical societies and guideline panels. And it's a multi-component approach to chronic insomnia that looks at common thoughts and behaviors that interfere with optimal sleep. It's traditionally delivered face-to-face, individual or group settings. And the various components, there's a behavioral component which establishes a stable bedtime, wake time 7 days a week, reduction in time in bed to approximate the total hours of estimated sleep, encouraging the use of bed only for sleep and sex, and I don't know why they limit it that way, but, and then try to sleep only when sleepy and get out of bed if anxious enough that you can't sleep. And then sleep hygiene includes avoidance of substances that interfere with sleep and avoiding naps to maximize the sleep drive and optimization of the comfort of the sleep environment. The cognitive components have to do with anxious and catastrophic thoughts that are associated with sleeplessness, inappropriate expectation about hours of sleep, misattributions regarding the effects of sleeplessness, and then the use of relaxation through progressive muscle relaxation, mindfulness, and meditation, back to the breathing that was mentioned before. So, yes, there is an app for this. It was developed at the VA. It's free. You can download it. It's meant in many ways to be used in conjunction with the actual individual or group therapy, but nevertheless, still very useful to have. And I think that, again, would be something that you could talk with an individual about downloading into their phone and make use of. So now we're into the final section here about grief and loss. So the APA Committee on Psychiatric Dimensions of Disaster and COVID-19 heard loudly from many sources that the kind of loss and stress associated and grieving that goes with this work needed some guidance. And so we came up with 8 different areas, and I'm going to touch on them briefly. So first is to recognize that exposure to death, including high numbers of deaths when healthcare workers and families are at ongoing risk themselves, can be an extreme stressor. Applying the principles of psychological first aid and well-being for disaster responders. Acknowledge the death and challenges associated with managing death. Consider individual responses to death, including the death of a colleague. Identify guilt, depressive affect, heightened feelings of personal responsibility, and other common cognitive challenges. Employ the principles of indicated prevention for those who develop distress or seek support. Of course, that's going to be really important for the work you're doing. Manage the pace of change with clear communications and use supportive approaches for teams and not forced critical incident stress debriefing groups. I can't emphasize that enough. We have studies to show that they're actually harmful, and the military switched from using them to using psychological first aid for that reason. So let's look at the first item, and that's the recognition about the experience of the exposure. So again, we have a situation where the frequency and the numbers of death that result from COVID really more closely with those seen in other major disasters. So again, we're having a situation where people who are not used to working in disasters are suddenly confronted with this type of reality. And so if you're not experienced either in dealing with dying patients or exposure to high rates of death, it could be particularly distressing, frightening. And treatment needs to be undertaken without adequate evidence base. Here we're talking about the circumstances that the physicians are finding themselves in. Very often, decisions must be made because of insufficient resources that exist to support best practices. So that's a huge stressor that needs to be acknowledged, especially when there's a death that has occurred. And physicians feel less connected to or more disconnected from their patients and their families due to PPE and the need for physical distancing, as well as the exclusion of families and loved ones from the bedside. A lot's been written about that. I noticed the recent JAMA publication had an article particularly related to that. So again, we talked about psychological first aid. I won't go through all that detail because of the time. We acknowledge the death and challenges with managing it. So we have, again, a circumstance of a heavy workload, high fatality rates, fear of personal safety. And we need to allow that and acknowledge that this is the reality of things, and that the direct impact of multiple deaths associated with this is often something unimaginable to a lot of the people, and we want to therefore honor the enormous efforts that they are making in this circumstance. But we also want to consider individual responses. That deaths can trigger individual in many different ways. Reminders of prior loss may trigger emotionally distressing responses that should not be managed in group settings. My own personal experience in dealing with disaster response and both community outreach, but also in shelters is, especially when the need for mental health is identified, that it's frequently related to the trigger of past traumas that people have unrecognized or had never spoken about. And I can think of a circumstance in Katrina where a Vietnamese man desperately needed to talk to somebody. Well, I was identified as the mental health person, and he wanted to tell me about how he had been sexually abused by a priest in Vietnam as a child. And this, he said he had never told anybody about this, and it was many years ago, but here we were in the situation of the disaster in Katrina where that was what bubbled up. So you're going to hear potentially stuff that they will never have told anybody. And as I mentioned, the value and the anonymity of these calls is that they can freely talk to you about stuff that they would never disclose to friends or neighbors or family. So just don't be surprised. Then, of course, the trigger of fears of one's own family, children's or parents' death can easily be a factor. So again, with the time, I'm not going to go read all of this. We want to identify guilt, depressive affect, heightened feelings of personal responsibility, or other common negative challenges. We know that people, all of us in this profession, just tend as a group to take responsibility for the outcomes of patients. We overestimate our responsibility in these outcomes, and it will undermine your capacity to continue function in your role if that's the way you get stuck. I have learned over the years, and particularly in my work in the VA, dealing with highly traumatized individuals and families and supervising trainees to explain that you need to think in the context of mitigation and long-term benefit that you can't see in the immediate context of your intervention. And I was taught this after 40 years of practice, really, as I actually got a chance to see people, children I treat, grow up, become young adults. Maybe they came back to see me and they remembered interventions that had happened during their childhood, including perhaps seeing me, and how important that had been to them. And I never would have been able to predict it earlier on. So just remember, you know, the value of what you're doing is something that will definitely be experienced and felt for a long time. So, all right, indicated prevention for those who develop this distress and seek support. Again, we're looking here about team support to a large extent and encouraging people in that regard to take advantage of team support that's available. But of course, it depends on the personal preferences of the healthcare worker. A hospital chaplain or religious leader or trusted mentor can also be very helpful. We don't want to only think in terms of psychiatry. And managing the pace with clear communications. Again, this is something we've talked about a lot, how important that is. And supportive approaches for teams without forced critical incident stress debriefing. Again, recognizing and normalizing emotions related to shared experiences, reminders about practicing self-care, recommendations for finding some time, however briefly, for respite and pleasurable experiences, respective individual differences and coping styles. This is really important. And I would say in the real role of culture here is really important too. There are either rituals or particular types of cultural positive experiences that would be useful to identify and reinforce. And so, again, paying close attention to that in terms of people's reactions in these circumstances of loss and death will be really valuable. So I'm going to conclude with what is at present an important message. If you are just arriving, thank you for what you're about to do. And peace to everybody. So I can stop screen sharing and we can go to questions.
Everybody hear me? There we go. I'm back.
Okay.
Thank you so much. That was wonderful. And just you gave kind of a perfect preface to next week's lecture, which will be on CBTI. So we're very excited about that.
Oh, good.
Okay. So just so everybody is aware, this has been recorded and we will upload it to the website ASAP. We can go ahead and start taking questions. So if you see the raise hand option, you can go ahead and use that, or you can type questions in the chat and we can go from there. I see there's been a request that you share the source for the psychological first aid handout. Would you be able to do that?
Yes, I answer that I can. That was my intent. There are also, just since everybody's able to hear, there are lots of resources I know you've already uploaded, and I'm happy to send both links and other resources that may have been referred to. So subsequently, if you all would just let me know, I would be happy to pass them on.
That would be great. Thank you. We have a question from Bernadette. Many callers have a lot of anger. How do you approach that?
Well, I think as was mentioned, particularly in the point about distraction and focus, I think it's important to just, again, through reflective listening, to be able to listen to the nature of the anger and help identify either the source of it, but also their cognitive behavioral techniques that have a lot to do utilizing mindfulness as well. I mean, I think getting stuck in it is the challenge. And so being able to step back more mindfully and be able to calm yourself down, and then to look at what's realistic and how to, what's the next step and what you need to do. But I think validation around the sources of anger is a critical component of that. And I think that, the dilemma for feeling out of control around anger, for example, you're going to try to help them sort of regain a sense of control in terms of what they can control and let go of what they can't control. It's a longer term process, but in the call structure that you have, that's the kind of hope and help that you want to be offering them at that time.
Thank you very much. What other questions do we have?
I was just wondering if you can go into more detail about critical debriefing. And I know that that's something we should avoid, but I have some sense of what you're talking about.
Sure.
I mean, when I was working at the state mental hospital, anytime something happened around seclusions or restraints, or someone got hurt, you know, people would stand around and talk about everything that happened, but it wasn't, I mean, that was more like a debriefing.
Right.
But, and that can be vicariously re-traumatizing.
Right.
And, but what is the better way of approaching it?
So the particular issue related to the protocol that was originally developed for critical incident stress debriefing was that it was done in the context of an ongoing first responder group. It might be military, or it might be fire or police. And this work group was required to sit down and to talk about not only what happened, but how they felt about it. And as you point out, that could be re-traumatizing. So there could be some real harm that comes out of that. And people aren't necessarily, in those forced encounters, people are also not trustful of the circumstances. So for example, you're in that kind of a context, reporting your thoughts and feelings that may, from your perspective, showing that you're weak, and you're reporting them to somebody who might be your supervisor. And so your concern there, again, is that maybe your performance review or some other fitness stigmatization can occur, and that puts your person into a double bind. So the concept that we're trying to get into is that opportunity for peer support, where people are allowed to come and talk about what they feel they want to talk about when they're ready to talk about it, can be helpful. And that's just one component of many different types of supports you would expect people to have. In the current climate, for example, what we have found is that at an academic center, for example, having a support group, we don't call it even that. We call it a time to sort of gather, and you create a theme for that group. It might be related to your career. How will the impact of everything affect your ability to either do your research, to pursue a particular specialty interest. You're now being asked to do general stuff, whereas your career is really dependent upon other sort of specialty training, but a lot of stuff will come up. And so that's very supportive to do it in that way. It's meaningful and it's voluntary. It's a very different type of group process than it would be if you had a forced, mandatory requirement that you now are going to tell us exactly how you feel about the trauma that you just went through. That help?
Okay. Yes.
Yeah. Okay.
What other questions do we have? I personally really appreciated the incorporation of some of the DBT acronyms. I think it's
Good.
easy to leave that off to the side sometimes, and they're very useful.
Good. Yeah, I would give credit in many ways to the content of this presentation to all my colleagues. We always share our particular perspectives and knowledge in a way that you may find even some of this material pops up in other presentations, but it's good to reinforce it. So.
Dr. Kim, did you want to, I said you see that you made a comment. Did you want to ask a question or make a comment?
Me? Yeah. I wanted to, I guess, I work with a smaller organization, and I was just wondering, how would I go about trying to get like a support group of some type started? How would a person do that, if you know?
Well, you mean for within your organization?
Yes, or outside, you know.
Well, I think there are many different ways to approach that, but particularly if you're thinking about it within your organization, again, I would think in terms of the work group that you're in, right? So if you're part of a team, you know, the natural time to do that kind of support group effort is going to be in the context of, say, change of shift. Everybody's normally there talking about stuff. You have a compassionate presence. You start to, you know, reflect on things that people are talking about. You give validation. You give suggestions. That will particularly over time evolve into effectively a support group. So that's within your organization, one thing you can do. Outside the organization, I know through the, for example, professional groups, North Carolina Psychiatric Association, we have very actively promoted and encouraged things like we call listening session, town hall. For some people we call it a living room chat. So it's like this, it's a Zoom call once a week in the evening. All members are invited to come. We have a psychiatrist who's a moderator who's done this for years in different contexts. And it's just a friendly, informal way for people to bring up issues and concerns and to make connections, really. It's amazing how you can be right in the same community next door to somebody and not even know they were there. And you can get to know them that way, and that can lead to other, you know, valuable types of engagement. So there's that, and then there's other volunteer organizations where support can also naturally happen. I know that in my work both at the Red Cross and also through some other disaster organizations, that we have planned meetings, for example, and usually those meetings incorporate what I consider support elements to them. It depends on the nature of who's there, but whether at the beginning of those meetings you want to have sort of a mindful moment, some sort of moment of silence, whether there's a particular topic of distress that people are recognizing in the community, that type of thing can be very helpful, and that has a supportive element. So whether you would think of that as a support group or not, I wouldn't necessarily restrict the way I would define a support group experience as being just about that. It can be incorporated, embedded in other meetings that you have.
Okay, thanks a lot.
Sure.
This has been very helpful.
I'm glad.
Thank you for giving this talk.
Well, I'm glad it was. It's good to be able to.
I see a raised hand. June Kim.
Okay, hi, I'm Jan. Thank you so much for the wonderful talk. I think I missed a little part of right before CBTI about dealing with death. Yeah, how do you support our physician colleagues who are struggling with seeing so many deaths and whatnot? And you mentioned something about something not to do, instead do this. And I kind of missed that, what not to do.
The not to do is one of the things we talked about, which is the critical incident stress debriefing, which is a forced mandatory circumstance where everybody is required to talk about the feelings and thoughts in reaction to the trauma they just went through. Everybody has a different style and way, and some of it's culture and some of it's just personal life experience, how they can process this kind of experience. And it's best to let people over time process it in their own way. So that applies to grief as well. So in terms of your question about how to be helpful to colleagues who are experiencing grief, loss, I think acknowledgement of the loss itself is one step, but also understanding in the context of how it happened and what it brought up to them, whether they are frightened because the person that died reminds them maybe of a family member, and they're worried that they might infect, and that might be the result of that infection. So you need to help clarify that. Whether people are particularly feeling guilty, for example, that they didn't do enough. That's a fairly common reaction for all of us who have a hyper sense of responsibility for all outcomes, and understanding that, you know, you've done the best you can, helping them find as best they can. Again, you're limited in a call, but make meaning of what happened. The spiritual aspect is not to be underestimated. So understanding what their spiritual beliefs are, and I'm not talking about formal religious necessarily. I can't tell you the number of times, especially with veterans I've worked with, where they'll tell me in a very defensive way, you know, I'm not a religious person, but don't misunderstand me. I'm very spiritual. And so understanding what that means to them and what would be a support would be also very, very important. Chaplains can be, and they're non-denominational, typically in hospital settings. So again, and the Red Cross has a form of grief intervention called the Intercare Condolence Team, which I'm part of. And that includes disaster mental health, disaster health services, which is typically a nurse, and a spiritual care person, which is typically a minister or somebody who is a pastor or from some religion. And the training that you get is about spirituality and respect for different religious beliefs. But it incorporates all three, because those are the dimensions that are very important in the process of grief. Interrupted grief is likely to be a main feature of what you're going to be hearing about, both from the point of view of you know, they may be the only person with that person who died, no family member. And that is in itself very distressing. So, yeah. I will make available some of these documents are available on the APA website, but I'd be happy to send them along to be posted on this particular website, so you all can have access to that material.
That would be great. Thank you. And I think Nancy Berkey has a question as well. I'm sorry about my dog, guys.
Okay.
Thank you, Allison. Yeah, I had a question. I assume that, and I'm new to the group, but I assume that a lot of the docs that call in come from have lots of different kinds of needs. But I wondered if you had a sense of what their expectation is typically from a call-in line, and are we meeting that, and how are we meeting that, and what is the what do they hope to gain? So it seems that you talked about the difference between this and an ongoing therapy that many of us may be more familiar with. Often this is a one-shot deal. And so maybe you could speak a little bit about their expectations, and are those expectations being met?
I'd be happy to answer it from my own experience and perspective, but in terms of this particular service, I am an outsider. I don't have that detail. I did ask similar questions to Mona when I first agreed to do this, but again, I think you're still collecting information on that. My guess is that there's a range of different expectations. Usually, typically depends on how a person heard about it, right? And what their circumstances were. My best guess is, again, that they're feeling desperate in some sense to talk to somebody, and without worrying about the consequences of what they disclose. And they may, on the fly, because they have a moment, find that it's easier for them to make that call than it is to arrange to go somewhere at a designated time to talk to somebody that is going to be supportive or not. So I think that, again, it depends on the past history as well, and it depends on the level of training. So I think what we do know from SARS is that the healthcare workers, physicians obviously here, who are less experienced, less well-trained, less familiar with the actual environment and circumstances of the service they're provided, are the ones that are most likely traumatized and going to be needing to call. Those that are more experienced and have the skill set may, in their own way, be particularly outraged and angry or distressed, but have other developed coping mechanisms and will channel, for example, appropriately some of their reaction to the appropriate authorities and to appropriate colleagues. But if people feel trapped within their own experience and they don't feel a way out of it and they just don't know what to do with that feeling, they're going to be the ones calling you, I think.
Thank you.
Yeah.
In general, Bernadette made a really good point. Sometimes they just don't know what to expect because they've never called us before. They don't know what we do. Callers who have called before have commented that they get a lot of validation from our volunteers. It's nice to just have somebody that they can talk to. It's nice to have somebody who has that shared experience with them, which is why we have focused on the peer-to-peer relationship. And I want to address just quickly before we end, there was a question about how do you prepare for your first call, and what on average are is the number of calls that you would receive during your 1 hour shift. And I just want to remind everybody that on the website, in the volunteer portal, there's an instruction sheet for how to actually maneuver the Telsio app. And then I'm available, and so are Smita and Mona, for troubleshooting on Telsio if you have problems. And as far as calls during the shift, it's highly variable. People will call later in the evening. So in the evening shifts, after work hours, calls tend to increase. Also, we've seen some spikes in calls during the lunch hour. So it's really variable, and the length of calls is variable too. So you kind of just have to play it by ear. Smita is back. Maybe you can sort of address that question as well.
Sure. So in one shift, you should expect anywhere from zero to 2 calls. I haven't had anybody who has had more than 2 calls in one shift. And I've sent an email with the subject of suggested reading and listening before you take your first PSL shift. What the email has is the encounter log that we create, which is no identifying information, but just general idea of what kind of calls we are getting. So you'll be able to see what other people have gotten so far, and the lectures that we do, and then FAQs for volunteers.
Bernadette, I think you're still muted. There we go. We still can't hear you, Bernadette. She's going to type. Pamela just asked, is it correct if the cell phone will ring with a different tone to alert you of the Telsio call? Yes. The Telsio app has its own tone.
Just to be mindful of Dr. Chrisman's time, We can continue talking about logistical questions for 5 more minutes. But if there are questions for Dr. Chrisman, I would appreciate if you guys prioritize those.
It looks like Bernadette is typing a question. Many
Okay.
callers are in between work and home, often with acute emotions. I think she's still typing.
Bernadette, give a thumbs up if you are asking a question.
Oh, nope, no question. Okay.
Okay.
Okay, so we are about 2 minutes from needing to wrap this up. If you have any follow-up questions for Dr. Chrisman or questions for us about logistics of the Telsio app or how to do a shift, you can contact us by email. So you can email Smita at admin@physiciansupportline.com. You can also email Mona or me, and we can all communicate about that. Thank you so much, Dr. Chrisman. This was wonderful.
Sure.
We really appreciate your time.
Let me just make the following parting comment. Never underestimate the value of your compassionate presence. It is always appreciated, and its benefit is hard to judge at the time, but it is always valuable.
I think that's an important reminder for us, as we are all physicians and we all feel like we need to fix things and use all these skills that we have and these modalities that we've learned over the years, but just being present. And I really liked what you said about reflective listening takes a lot of concentration and a lot of focus. So I think that is very valuable.
Thank you for the opportunity to share the information, and I wish you all the best.
Thank you.
Yeah.
Thank you.
Okay. So if anybody has questions, go ahead and just email them to us and we will follow up with you. And thank you so much for all being here. This was great. And thanks for tolerating my dog barking.